So I'm really delighted to welcome Felicity Waite to kick off the first seminar of this year. Many of you will probably know Felicity, but for those who don't, she's a clinical psychologist and deputy lead of Oxford Cognitive Approaches to Psychosis research group in the Department of Psychiatry. And her work focuses on developing more effective and more easily accessible interventions for people experiencing distressing delusions and hallucinations. And she also has an interest in youth mental health and the potential for psychological interventions targeting key causal factors to prevent the onset of mental health problems. So Felicity is involved in a whole load of studies, including the Game Change project, which uses virtual reality to help patients with psychosis build confidence in everyday social situations. She's just literally last week started a Wellcome Trust doctoral research fellowship, which will focus on developing and testing a novel psychological intervention to build positive self-concept in people with psychosis. And she's also leading a new NIHR RFPB funded trial called SleepWell, which is all about preventing the onset of psychosis in those at highest risk by treating sleep disturbance. So we're really looking forward to hearing more about this today. So thanks ever so much, Felicity, for joining us, and I'll hand over to you.
Thank you, Kathy, and thank you for the very lovely introduction. And it's so nice to see so many familiar names, even though I can't see faces this morning. So thank you so much for joining us wherever you may be. And what I would like to share with you today is to begin thinking a little bit about how treating sleep problems in young people who are at ultra high risk of psychosis, and in particular the SleepWell trial. So why this topic, why this treatment target, why this group of young people? Well, we know that 75% of mental health problems have their onset before adulthood. What that means is we have the opportunity for a timely and targeted preventative intervention, where we could have the opportunity to prevent the onset of more serious mental health problems. And this, of course, is important for the young person, for their family, for their well-being, but also there are clear implications in terms of value for money. We have seen in the evidence that we can have effective interventions that have clinical benefit, but that are also cost-effective when we evaluate interventions in the ultra-high risk group in young people in research trials and in routine clinical services. Those at ultra high risk of psychosis are young people who are experiencing psychotic-like experiences, who are also struggling with day-to-day life, who are noticing a disruption in their functioning and are having some odd or unusual experiences, often in the context of low mood and anxiety, and typically they're help seeking. They're coming and they're asking us for help. So the question begins, what can we do to intervene with this group to treat the problems they're currently experiencing, and also to hopefully have a knock-on benefit for wider mental health and prevent more serious long-term mental health outcomes and problems. And there is a standout causal factor, and that's sleep disturbance. Now, all of us know the impact of a bad night's sleep. Of course, we've all experienced that at some point in our lives, but actually, the research and clinical services have been a bit slower to kind of catch up on this, really. And so traditionally, sleep disturbances within mental health problems were conceptualized as a secondary problem, a kind of epiphenomenon, that they were just a part of the depression or part of anxiety or part of the psychosis. But in recent years, this idea has really been turned on its head. And what we're seeing is the reconceptualization and recognition that sleep disturbance is actually a contributory causal factor across a whole range of different mental health problems. This really matters because it kind of shakes up our conceptualization. We can kind of step away from the diagnostic categorization where sleep disruption was just a common and non-specific phenomenon. And of course, the diagnostic categories invite us to attend to what is specific, what is different between presentations, rather than what is common, what is similar amongst them. In contrast, using the novel kind of network approaches, where we're looking at networks of contributory causal factors for mental health outcomes, we can see is that those common non-specific factors might carry an even more importance, because by targeting those, we might have the potential to see knock-on benefits across a whole network of mental health problems. And over the last few years, we have seen this real shift in understanding for the importance of sleep disruption as a causal factor in the occurrence and persistence of psychotic experiences. In this recent review that was led by Daniel Freeman in the department, we're really beginning to draw together and show that common impact of sleep disturbance across a whole range of mental health problems. And importantly, this review highlighted that perhaps treating the insomnia, treating the sleep problem, might lessen other mental health problems. And if we treat it early, potentially it's a preventative strategy for the onset of clinical disorders. That's what we're interested in the SleepWell study. If we treat sleep problems in young people at ultra high risk of psychosis, can we not only see the benefit on the sleep disturbance, but also the knock-on benefits for mental health? Do we see reductions in depression, anxiety, psychotic experiences, and hopefully reduce the risk of a transition or the onset of psychosis? And the research evidence is really strong. We're seeing that when we treat insomnia, we see knock-on benefits across a whole network of psychopathology. In this trial that was led by Daniel Freeman and Colin Espy here in Oxford, there was a test with over 3,500 students, and they were testing the effects of a digital CBT intervention for insomnia. And they found that not only were there large effect size improvements in insomnia, but there were knock-on benefits across the whole network of psychopathology. And a particular interest for the SleepWell study, what you see are small but very important reductions in effect size improvements in hallucinations and paranoia. This, though, was a non-clinical study. What we're interested in SleepWell is now taking that work forward and thinking about it in young people at ultra high risk. What we see consistently across the research evidence is when you use CBT for insomnia, which has over 100 randomized control trials, and we see very strong evidence for the psychological treatment of sleep. When we see improved sleep, we also see important improvements in mood, particularly in depression, and to a smaller effect, anxiety. And we see smaller effect size improvements in psychotic experiences too. These are smaller than those seen in depression and anxiety, but very important nonetheless. And it's this route that we think that the improvement in psychotic experiences come, that if we can improve mood, depression, anxiety, that's the mechanism through which the psychotic experiences are improved too. And we've seen this not only in the large trials of, in non-clinical groups or not including people with psychosis, but also over the last few years here in Oxford, we've done a series of small case series and pilot randomized control trials testing out sleep interventions with patients with psychotic experiences. This has included testing it with patients with persistent delusions and hallucinations in the Better Sleep trial, and those in acute inpatient psychiatric ward in the OWL study. What we see from these small studies, which are not powered to be conclusive for the effects on psychotic experiences, but what we do see very consistently across all of these studies are very large effect size improvements in sleep. And in the clinical groups, we see very high uptake of therapy. In fact, in the OWL study, the uptake of therapy was 100%, which I think has surprised many people in thinking about delivering psychological interventions in an inpatient setting. So what I would argue is that sleep disturbance is a potentially treatable causal factor in the onset of psychosis. That's really important because what we want to do when we're tackling young people at ultra high risk of psychosis to try and offer a benefit is to treat a problem that is of importance. My slides have got a mind of their own, so I'll try and keep them behaving. We want to treat a problem that is common, that is tractable, and that has the potential for knock-on effects. And sleep disturbance is one such factor. And I really want to thank the work of the Sleep and Circadian's Neuroscience Institute here at Oxford that has helped to drive forward so much of this research and to support the SleepWell study to date. So that's our treatment target. Our group are young people at ultra high risk who are aged 14 to 25. And what we want to see is, well, can we treat these sleep problems and see the knock-on benefits? And sleep problems are enormously common in this group. Around 75% of young people at ultra high risk have a sleep disorder. And why does sleep matter so much in adolescence? Well, put simply, adolescents need more sleep and yet they get less. There is a crunch point for adolescents, a squeeze on their sleep. And this is because there are changes in the biological drive for sleep and the circadian rhythm, the timing of our sleep, and also changes in our social world as adolescents. Of course, we might have more independence, there's more opportunity for socializing, and so we tend to see that adolescents are staying up later, firstly driven by the biological shift in circadian rhythm, the timing of our sleep, so that adolescents, put simply, just don't feel tired until later. And so they go to sleep much later, but school, college, university, work, that all demands that young people are up at the same time. And so their sleep opportunity gets squeezed. But it's not just this that we see in the young people at ultra high risk of psychosis. We also see that there are shifts in terms of disruptions in terms of sleeping too long, hypersomnia, disruptions in terms of insomnia, difficulties getting to sleep, staying asleep, or waking up too early. And we also see other problems like nightmares and parasomnias. And when young people do have sleep problems, actually the consequences are marked. There are huge consequences in terms of physical health, in terms of functional and academic outcomes, and also on mental health outcomes. When young people aren't sleeping well, we can really see it across the whole spectrum of life. And this means it's a really important treatment target in its own right. In SleepWell, we're interested not only in treating it for the benefits on sleep, but also these knock-on benefits on mental health. This is what one of the young people who took part in our case series said. "I would just sleep through the day, and that put a massive strain on my social life, my mood, my mental health. It turned my life the other way around. I'd be up at night and then I wouldn't be up in the day, wouldn't go out and see people because I was sleeping. I think it was very unhealthy." And this means then what we did is we took this, sorry, my slides are going again. We took this approach of wanting to treat the sleep problems in young people, and we started with a case series. We were interested in what would happen if we were to treat sleep problems in young people at ultra high risk of psychosis. So we worked with 12 young people here in Oxford Health, and you will see from the paper, huge thanks to many of the local clinicians and colleagues in the Department of Psychiatry for being part of this project. This initial case series was our first chance to begin to test out what might happen, whether it was feasible and whether it was acceptable to treat sleep problems in this young patient group. We worked with 12 young people, 6 young men, 6 young women. The average age was 18. The selection criteria was for people aged 14 to 25. What we were working with, they were recruited from the CAM services and the early intervention teams here in Oxford. We were offered people 8 sessions of a CBT intervention that was targeting sleep disruption. The sessions were delivered on a one-to-one individual basis, but they were highly manualized so that we were able to provide very consistent therapy, very highly protocolized, but also the manuals allowed patient choice so that the young people would identify which were the particular presenting problems and what were the particular strategies they wanted to try out. And so it was this combination of patient choice and highly manualized that provides our therapy. And the therapy targets the 3 key factors that we know to drive sleep and sleep disruption. So firstly, our sleep is dictated by our sleep pressure, our propensity or need to sleep. And this increases each day with the amount of time that we're awake. So when we're targeting sleep as a treatment goal in therapy, we want to increase sleep pressure. The second is our circadian rhythm. This is our biological clock. It's the rhythm or timing of our sleep. Now, each of us are kind of working through a 24-hour sleep cycle each day. where we have peak times when we are most sleepy and have the most propensity to sleep, and times when we're most alert. We're just coming up to the time where people will be having that natural dip in energy usually just after post-lunch. So hopefully it won't hit you too hard yet, but it's really powerful to see the circadian rhythm and the impact this has on our timing of sleep. And this is really important because this is one of the key things that shifts in terms of adolescence. The sleep pattern shifts. So we want to tackle the circadian rhythm and try and align sleep with nighttime and activity with daytime. And it's actually light that is the key Zeitgeber, the key anchor for our circadian rhythm. And that's because each cell in our body is dictated, has a clock, which is giving us this peak time for each of the bodily functions. And all of that driven by the suprachiasmatic nucleus, which is particularly sensitive to the light receptor in the eyes, which indicate whether we should be awake or asleep. And for more information on that, I'd really recommend checking out the work of Russell Foster, and he has a lovely TED talk explaining that. So in the therapy, we want to increase sleep pressure and get the timing of sleep aligned so that people are asleep at nighttime and awake in the daytime. The last really important factor that we need to address in the therapy is to reduce pre-sleep hyperarousal. Now, many of the young people we work with will be on edge, they will be feeling anxious, they'll be feeling low, and what we see is that our arousal system, our alerting system can trump that sleep pressure or that circadian alignment, and that means our sleep can be disrupted. And so in the intervention, we sought to increase sleep pressure, align the circadian rhythm and get the timing right, and reduce pre-sleep hyperarousal so that young people felt calm and safe in order to get to sleep. And what we found is that all of our indicators of whether the therapy was acceptable, we found that actually all 12 of the young people approached, consented to take part, and 11 of them completed the therapy. The attendance rate was really high. We found just under 90% of the sessions were attended, which is very high given this is a young group where life is often complex and complicated. And yet we found that the sleep intervention was very popular. And in terms of the many questionnaires that we ask young people to complete, the data completion rates were very high. In fact, only one item was missing, apart from when it comes to sleep diary data. So we found that it was really tricky to ensure the completion of the sleep diary data. In fact, this was our one area of the trial where we found high levels of missing data. In terms of the clinical outcomes, and I just want to highlight again, this was an uncontrolled case series with just 12 young people. We did see exciting improvements in the clinical outcomes, and I just share them with you to say that we think this case series gives us the indication that it's worth us pursuing sleep as a treatment target for young people at ultra high risk. We saw large effect size improvements in insomnia and sleep outcomes, and these knock-on benefits across these different areas of mental health outcomes. And one of the young people, one of their reflections, well, they said, I now have the energy to do those things that I normally wouldn't have done because I was physically just too tired. And that makes me feel happy because I'm getting stuff done. I'm not getting stressed out. It makes me feel happier. We're really excited about this work and keen to take it forward. And so we conducted a qualitative analysis with young people who'd taken part in this first case series to find out a bit more about what it was like taking part, what the sleep problems were like, what the therapy was like, how could we improve it? And the young people talked to us about 3 key themes that were identified: their experience of sleep problems, the process of the therapy, and the utility, the usefulness of the therapy. Just to share some of their insights, when talking about the experience of sleep problems, young people really recognize this reciprocal relationship between their sleep problems and their mental health and functioning. And they said, actually, sleep problems, it makes everything a lot worse. They also recognize the importance of sleep timing. One young person said to us, it was just a lot of sleeping at the wrong time. I could be like staying up till 2, 3 o'clock in the morning, then going to sleep, and then I'd be napping for like an hour or 2 during the day, and then staying up all night because I hadn't slept during the day. And so there was this recognition of the importance of circadian rhythm and of the interaction and reciprocal relationship between sleep problems and mental health and functioning. In terms of the process of therapy, young people had very negative expectations of the therapy to start with. So one person said, I didn't think it would work at first. But throughout the therapy, what people noticed is that they gained a lot of understanding about their sleep. They began to become kind of experts in sleep. And they also developed many different types of strategies. And they said that these required a lot of hard work to try out, but also that there was a spirit of kind of try and do. As one person said, I've got a repertoire of skills now. It's been a process of trying things out. I can just go, right, let's try this. If it doesn't work, I can try this. That works a bit, I can try this, and that works even more. And so there was this spirit of curiosity, of discovery, of trying out new things, and of gaining a bit more control and autonomy. Lastly, young people shared with us their views on the utility of therapy. They said that it was a really valued experience, that actually they quite enjoyed the therapy, and also they noticed important improvements and changes following therapy. They said actually everything's kind of eased up all at the same time. And they just explained this, and they said it's because it's so highly linked with sleep. When I sleep better, I tend to have a better day. I find it also helped my anxiety a lot. I'm better able to cope with situations, and I kind of stay in control, which I think has come from me gaining control of my sleep a bit. So there's a kind of insight from what some of the young people shared with us about their experiences. And we wanted to take all of this learning together and shape the work that we're doing. And so in terms of collecting data, the key learning from the case series is that paper sleep diaries really didn't work. We really struggled getting the data. What worked a lot better was using wearable tech devices. So using Acti watches, using Fitbits, Garmins, iWatches, all those sorts of things that young people were really keen to see, and also then being able to use some of the feedback data that these programs deliver. Young people were quite excited about seeing the patterns shift in this, and that seemed to work really well. In terms of clinical adaptations, well, technology features there too. We found that that was important to shift from technology being kind of seen as a barrier in therapy to how can we use it best as a tool in the intervention. We also thought a bit about who needs to be on board for making changes to sleep and how to manage some of the key aspects of the sleep interventions like stimulus control, learning to associate bed with sleep when, well, your bedroom's your only private space. So in terms of technology, we tried to find ways that either the young people could use their phone or device as a route to mapping out, collecting data, becoming an expert in sleep. We also had to do a few behavioural experiments with finding out what happened with blue light and what happened with using our phones late at night, and what it meant to not be in contact on social media or emailing, connecting with friends late at night, what the social implications of stepping back from nighttime use meant. What we tended to find is that by experimenting, by inviting people to be curious and discover for themselves what the potential costs and benefits might be, that young people reset their own boundaries around this to reach their own goals with improving their sleep. Also, we had to think a little bit about energy drinks. Now, many of us might be having a cup of tea or coffee at the moment, but what we noticed with young people is caffeine is incredibly present, caffeine and sugar, but instead of teas and coffees, it came in the form of these huge cans of drink. I don't know why, even the cans themselves seem absolutely enormous, and they are absolutely packed with caffeine and sugar. And so again, we invited young people to experiment with what happens to energy levels when we're fueling ourselves with caffeine through the day. What happens to our sleep when we reduce caffeine intake? And importantly, sleep space really matters. So in the traditional CBT for insomnia work that's traditionally been developed and tested with adults, there's the invitation to reassociate bed with sleep. And that means only using bed for sleep and sex and nothing else. That's really hard for adolescents and young people when their bedroom might be their only private space. It might be the space that they're expected to study and work in and socialise in and watch telly and relax and sleep. And so we had to kind of find ways to re-navigate that space and allow the principles of stimulus control, bed equals sleep, to be reset, whilst also finding spaces in the room where people could work or study or connect with friends. And this meant getting other people on board, whether that was family, friends, partners, tutors, housemates, bosses at work. We found that young people really needed a sleep team, those people around them that could really help them achieve their sleep goals. So the story so far, from our initial case series, we found that it looks like the intervention is feasible and acceptable, and there might be some potential clinical benefits. But of course, this is a cause for pause because this is a small, uncontrolled case series with just a very brief follow-up period. The intervention was delivered in around 8 sessions across 12 weeks, and the follow-up period was just 1 month later. And one of the key outcomes we wanted to find out was about sleep diaries, and there was a problem with sleep diary non-completion. And this case series gives us no indication of the potential cost effectiveness of treating sleep problems in young people at ultra high risk. And so we began thinking about what the next steps might be for this study and this programme of work. And our goal was clear, that we want to reduce the number of young people at ultra high risk who go on to develop psychosis by treating their sleep problems. And as Kathy mentioned, we applied for a Research for Patient Benefit grant from the NIHR, and we've been funded now to begin conducting the SleepWell Trial, a feasibility randomised control trial with 40 young people who are experiencing sleep problems and who are at high risk for psychosis. We're really excited because this study has just launched here, and it's open to the young people across Oxford, Buckinghamshire and Berkshire. This study has been developed with a huge amount of input from a fantastic lived experience advisory panel facilitated by our colleagues at the McPinn Foundation. The McPinn Foundation is a charity that exists to put people with lived experience at the heart of mental health research. And they've been absolutely fantastic at giving us feedback and input into the design of the study. They were involved in the grant application, the study protocol, the study documents, the name of the study, the logo, all the key aspects. But importantly, they shaped this study. They've extended the follow-up period. They've helped us think about what goes into the treatment sessions and the manuals. And most clearly of all, they have advocated for the importance of this topic. And although I'm stood here today, this has been a huge team effort. We have a fantastic co-applicant team with colleagues, many of whom will be familiar to you, but I particularly want to highlight Emma Chernis, who's the trial coordinator and clinical psychologist here in Oxford, Ellen Iredale, who's the research assistant and who will be particularly conducting assessments and recruiting and meeting young people, and Ariane Petit, who's been incredibly helpful in driving the study forward and getting us all the right ethics approvals in place. And for anyone who's done that, you'll know that's a huge amount of work. So those are our key kind of colleagues in this team, as well as the fantastic support of our collaborators and grant holders involved in the statistics, the health economics, and providing that expert advice in terms of the patient experience and clinical conceptualizations. But there's a whole wider advisory team to thank and acknowledge as well. Actually, this study has really benefited from the input of incredible and very inspiring colleagues across the field, and thanks to them for shaping up this project, thinking about expertise in treatments for sleep disturbance, for working with young people at ultra high risk, thinking about qualitative methodology. And we have our data monitoring and ethics committee, and that's chaired by Matthew Broom, who will be familiar to many of you as well. So this trial, we're going to work with 40 young people aged 14 to 25. People will be recruited from child adolescent mental health services, from early intervention in psychosis services, and also from the talking therapies, IAP services. We wanted to make sure that in this trial, we are open to young people accessing the potential to take part in the study from any of the clinical services that they might be in touch with. Young people coming into the study will be completing a first baseline assessment and then a follow-up assessment at 3 months and 9 months. It is a randomised trial, and so half the young people will be receiving the new sleep therapy and half will be continuing with their usual care. For those people who do not get the sleep therapy, we're offering a one-off session with a psychologist to think about strategies to improve sleep right at the end of their participation in the trial. We'll also be conducting a subset of qualitative interviews with young people to find out their experiences of taking part in the study. So our participants, and for those who are clinicians in our local services, please do consider if there are people that you're working with who might benefit from taking part, might be interested. Working with young people aged 14 to 25 years, that's that peak age of onset for psychosis, so we want to reflect that. Patients, as I said, of the local mental health services who meet the diagnostic criteria for being at ultra high risk of psychosis, and that's assessed using the comprehensive assessment of at-risk mental states. And young people who are currently experiencing sleep problems for which they would like help. So these are help-seeking young people. In terms of the exclusion criteria, I just want to flag that at the moment we have an additional, hopefully temporary exclusion on young people who are at moderate or high risk for a severe course of COVID-19. Like all aspects of our lives and our work, we're wanting to be particularly considerate about the impact of COVID, how to minimise that on the trial, ensure as much access, but also ensure the safety and well-being of the participants. So the treatment, as I said before, this treatment is about increasing sleep pressure, realigning the circadian rhythm so that the young person is getting their timing right, and reducing pre-sleep hyperarousal. What that looks like in practice are two key targets. Firstly, stimulus control, bed equals sleep. So that's about reducing that pre-sleep hyperarousal so that bed is seen as a relaxing, calm place. And when we go to bed, we just drift off to sleep. But also for the young people, it's really important about setting the sleep window. This is about getting the timing right. So this means getting young people to bed at a time when they feel sleepy, but that also gives them a long enough opportunity to get the amount of sleep that they need to feel really refreshed. And what was very clear from the case series is that we have all of this in collaboration with the sleep team, those people who can really make an impact for how young people can put this into action. For this feasibility randomized controlled trial, what we're looking for are the indications of whether we can recruit to target, whether we can meet this recruitment of 40 young people and whether they want to stay in the project, whether we can meet the data completion and the treatment uptake. And so we have feasibility markers and indicators for this trial. We've got stop and go criteria, and we're hoping we'll be hitting those. We're also interested, of course, in the clinical outcomes, in thinking about psychotic affective symptoms and in terms of sleep disturbance, quality of life, but also the things that really matter for young people. So their social functioning. Are they alert and bright enough and awake at the right times of day that they can get out and hang out with their friends? Are they kind of benefiting from their physical health? And of course, we're also interested in service use and how much and where young people are getting and accessing support. The SleepWell Trial has now been registered, and you can find out more details about the project on the ISR CTN registry. And the next steps are very exciting. So just to say, we are open. The SleepWell Trial is launched now here in Oxford, Buckinghamshire and Berkshire, and we would be delighted to work with young people that you might know. So if you would be interested in making a referral, then please do get in touch with Emma, Ellen, myself. There's lots of contact details for you. In this project, what we're interested in is finding out if we can treat a problem that young people find as distressing and disruptive to their lives, the sleep problems, and whether treating sleep problems will also have the knock-on benefits in terms of mental health. Can we see reductions in depression and anxiety and psychotic-like experiences? And does that mean that we reduce the risk of onset of psychosis in those who are at highest risk? And although it's me stood here in front of you today, I want to say a huge thank you on behalf of this fantastic team of people that I'm very privileged to work with. So thank you so much on behalf of all of us, and I look forward to working with you all on the SleepWell study. So thank you very much.